It's a great pleasure to welcome you all. Today's session Meet the Expert Oncology Treatment Updates. And I would like to invite for the speaker, Dr. Nihanti Dia, DS, uh, Consultant Medical Oncology and Hematology, Saroj Gupta Cancer Center and Research Institute, Kolkata. And to talk about how to proceed lung biopsy, principles of molecular and biomarkers analysis. So it's over to you, Dr. Nihanti.
Thank you, Geetika. I thank all the sponsors for giving me this an opportunity to talk over here. I'll be sharing my screen. Is it visible?
Yes, ma'am.
Okay. Yeah. Good evening, all. My name is Dr. Niyanti Srinath. I'm a consultant at Medical Oncology in Saroj Gupta. I thank all the sponsors and the Cancer Research Foundation for giving me this opportunity. Without wasting a lot of time, today I'll be discussing regarding the biomolecular testing which is used in lung cancer. So my presentation overview would be incidence of lung cancer in India. What are the various biomarker testing is being done and how did the evolution start and the final take-home message. So just a brief introduction regarding the lung cancer incidence in India based on the Lobocon study. If you look into the lung incidence, it's almost 5.5%. And it also leads to one of the increasing cause of death in our country. So looking at this background, why do we need to get all these patients tested? If we all know that lung cancer has an umpteen number of molecular derivatives and various targets which are being present. With every target, there is increase in the overall survival. So with this, the major testing which has been done and incidence of gene mutations are seen in KRAS, which is almost like 25%. Then comes the ERAS, EGFR pathway mutation, 17%. And there are other ones remaining like ALK, MET, HER2, and ROS, and all these testing mutations can also be seen. So I'll be explaining in detail that what are the various testing methods, how to go about it, and just a brief note about various targets used. So why is this biomarker testing important? As I discussed, if you look into this Kaplan-Meier graph, one second, I would just want to use my pointer. So if you look into this Kaplan-Meier graph here, the patients who had a driver mutation versus the one who didn't have a driver mutation, and based on the driver mutation, if you are going to give a specific target, they're increased in the OS. So, and also one most important thing is quality of life, which has to be kept into mind. So because of which there is various guidelines recommendation have come, let it be the ASCO, the NCCN or the ESMO or even the CAP guidelines. We have various testing from 8 gene panel, 12 gene to 18 gene. But at least the basic which a patient of either locally advanced or even a metastatic should undergo is EGFR, ALK, ROS, the BRAF mutation, MET exon skipping, RET, NTRK, KRAS, and important one is PDL expression also. So what are the various types of testing? Most commonly, we are dividing one is a DNA sequencing, mainly by the insertion of point mutation. The common platform of testing driver mutations are the EGFR, KRAS, BRAF, HER2. It can be a single gene or a full NGS sequencing. And other is an RNA sequencing panel. Mainly the fusion abnormalities uses the RNA panel, like the ALK, ROS fusions, or the RET or the NTRK fusion. Other tests like even IHC and FISH, ALK and ROS is one good example. Importantly, for the IHC, PDL1 and the MMR expression can also be taken into consideration. So how did the evolution start? So if you look into this diagram, this is mainly the workflow. When a patient comes to your OPD, what is the type of biopsy? And after, either it can be obtained by a fresh frozen block or with a circulating tumor DNA. And finally, we extract them. And finally, the latest development is the proteomics and all. So this is a basic workflow which depicts very well about how to proceed further. And I'll be explaining the differences in in FFP tissue and also in case of liquid biopsies also. So most importantly is even now biopsy stands as a gold mark. Why so? Because it enables in identifying the histology, let it be squamous or an adenosquamous histology. And other important pathway is it also enables us the adequacy of the tumor cells. So various driver mutations like EGFR, ALK-ROS, and MET exon, everything can be done on a biopsy specimen, including the PDL1 expression. So, which are the patients in whom a liquid biopsy or a circulating tumor DNA can be used? Mainly in which there is a dilemma and patient doesn't have an adequate biopsy tissue, or in those cases who are in a very poor PS and in whom invasive procedure may not be adequate. So mainly we need to look into the diagnosis and treatment selection. And more importantly, for doing a liquid biopsy, especially in case of a monitoring the prognosis to response, whether they respond well or in case of a progression or in a relapse, we can even look into the various mutational status which can be seen further. So has this liquid biopsy replaced the standard gold standard biopsy? Till date, we can't. But maybe if there is an heterogeneity, for example, you pierce a needle and if there is a necrotic material available and that turns out to be negative, maybe in those cases, definitely yes, liquid biopsy holds good. But currently, still the gold standard is a tissue biopsy. For molecular testing, maybe still a complementary can be done on a liquid biopsy. So, and other advantages are liquid biopsy just because it's less invasive, but most importantly, the cost has to be kept into consideration. So, there was a study conducted called the Tracer study where they had taken the 24 early lung cancers. So, what did they do? They divided this into two subset. They underwent a treatment and post the treatment, what is the response? So there's something called an MRD, which is commonly used in hematological malignancy. So the similar principle is also accepted here. So based on this, if a patient has a good MRD, it indicates that response to treatment is good and they have a longer OS. And there is any residual MRD or a persisting negativity or a positive MRD indicates that the response to treatment is poor and there's an indication of early relapse. But the number is quite less, so this has to be taken into consideration. So this is a brief slide explaining what are the difference between the tumor tissue and the liquid biopsy. Basically, tumor tissue is still the gold standard, but mainly invasive procedure. And again, it mainly depends on the person who's quite qualified doing it, interventional radiologist. And again, it depends upon the sensitivity per se and substantial evidence also for targeting. Again, if you look into the liquid biopsy, it's a simple sample procedure done 10 ml. If there's a good shredding of tumor DNA into the circulation, it's high sensitivity and high specificity, but it's not a gold standard. This has to be kept in mind. But in case of in a patient with a poor performance status where an invasive procedure can be avoided, this is still complementary and is taken into consideration. So here's just a schematic diagrammatic representation that when a patient who has successfully been tested, what are the various targets being used? So now coming to the advantages of the next-gen sequencing. So what is it? As we all know that lung cancer has an holistic tumor way approach, and most common, there are multiple driver mutations. So this also enables us to identify a passenger mutation and a driver mutation based on the allelic numbers. And this says that which target can be given first. For example, if there is a patient has a simultaneously two mutations, there's an ALK mutation and also an EGFR mutation. So how are you going to drive it? So we do have some allelic numbers on that. Based on that, the further added therapeutic benefit can be seen. So if you're doing a single gene panel, again, you can't understand what is the various proceeding pathways. Thus, a multi-gene panel is always recommended. Again, if you're doing a multi-gene panel, maybe the drawback would be the turnaround time. But these days, a lot of labs do give us in a span of week to 15 days duration. So the next gen sequencing can either be with the single nucleotide variant or the CNVs. Again, it can be depend on what do we want. We do want a DNA based or an RNA based. For example, like fusions can be well defined with RNA based sequencing. So here are the tests of the panel, which I'll be explaining in detail. So first coming to the foremost important mutation, which we all know is the EGFR mutation, which is seen in the lung cancer. So the common type of testing again can be the biopsy specimen, the fresh frozen plasma tissue, or it can be the cell block, even with an ascitic, even with, for example, with a pleural fluid or the ascitic fluid being positive, if there are adequate cells, the EGFR testing can also be done. And more importantly, yes, various EGFR mutation pathway, like we do have different exon 19, 20, 21, all these mutational pathway analysis can also be done. So currently the recommendation is, yes, if all patients, EGFR has to be done, even a single gene testing. First thing, affordability, if EGFR1 is the most advised one. So what are the advantages? If again, it depends. The most important part which we need to keep into focus is always the affordability. NGS definitely holds good, but what are the advantages of NGS over PCR is there's a study which shows that almost 48.6% of exact 20 mutations were identified when compared to even these days we have other various uncommon mutations which are being diagnosed in EGFR 19, 20 or 21. So all these subtypes can also help us. The EGFR variants can be identified. Based on this, the therapeutic implications have changed also. So coming to the next target, which has been available for us are the ALK rearrangement. So we all know that ALK can also be done with IHC, FISH. Yeah, there are various things. ALK IHC sensitivity is almost 93 to 100% compared to the FISH. But most importantly is the FISH positivity rate is 0.1%, which has to be kept in mind. So currently we also need to know into the economic consideration. There is something called as an economic oncology, which plays important role currently at this scenario. One is you treat the patient at the same time, you make sure and adequately an entire panel is covered. So coming to the ROS rearrangements, again, so this is the various pathways. First, basically, if a patient, any day patient comes to us, we get the basic single gene, or if the patient, currently you should advise at least a 12 gene NGS panel, and then you get the EGFR and ALK-ROS testing. Next comes the ROS. ROS can either be by IHC or the FISH. So main thing is a reconfirmation method is very important because of the false positivity and increased sensitivity also. So if you look into this diagram, which knows that EGFR pathways which have been present on the cell membranes, these are the downregulatory pathways, the RAS mutation, RAF and the MERK and the ERK1, finally go into the cell nucleus and hamper the cell proliferation and all. So which is almost seen in 30% of lung cancer. Most importantly being the codons variant on the 12 and 13. This G12C is important because of the current target, sotorasib, which is available. Then again, the downregulatory pathways, if you look in detail, after the EGFR and the RAS, we have the RAF pathway, finally downregulating into MEK and the ERK pathways. BRAF V600 He mutation in specific is almost seen in most of the patients, especially in smokers. And almost 1 to 5% expression can be seen in adenocarcinomas. So again, what is the platform? NGS is the best platform for the detection of BRAF testing. And more importantly, with the BRAF, we even get the MEK signaling pathways also if you look into your NGS testing. So coming to the next target which we are dwelling in is the c-MET receptor. Basically, this is a tyrosine kinase. So normally what does it do is, whenever we have, there is a normal splicing versus an aberrant splicing. It's like basically the protein secretions have been altered from a DNA to pre-RNA to an mRNA. But whenever there's an aberrant splicing leads to a skipping mutation. So finally, we need to look into this pathway in cancer, which is called the MET exon 14 skipping mutation. Almost it is present in 3 to 4% of non-squamous cell carcinoma. It can also be seen in a sarcomatoid variant. The expression is almost 20 to 30%. High sensitivity is by the DNA NGS testing. And you can increase the sensitivity further by the RNA NGS platforms also. So again, what is the recommendation? Usually IHC and FISH is not. PCR can help in some of the conditions. Ideal platform is an NGS, a DNA, and maybe if you need to increase the further sensitivity, RNA platform is still preferred in these cases. So coming to the next, that is the RET receptor tyrosine kinase. RET is again a fusion protein which has been seen, mainly which is a wild type RET gets into the fusion changes which occurs. Again, this has been incidence seen in 1 to 2% of the non-squamous and 10 to 20% most common in the papillary thyroid carcinomas. So again, the detection is by mainly the NGS platform with a DNA, and in more specificities, it can be with RNA platforms. So again, if you look into the comparison with IHC and FISH, you can do it, but there is increase in false negativity rates. So better with a DNA. And in case of a higher sensitivity, they can be done with an RNA fusion gene proteins. So next, coming to the other important fusion protein is the NTRK fusion. These all which we have dealt, let it be the RET, MET, or the NTRK, are the recent ones which have been implemented and integrated in the lung cancer, because we have found the various targets available, and they've also shown a very good improvement in both the OS and the median PFS of a patient. So the sensitive platform is the RNA NGS. We can still get with, for example, like you need to get, if the turnaround time of the NGS is quite high, maybe an IHC can be advised, but it's better to get it done on NGS. We do have something called a reflex NGS, which compares with the IHC reasonable testing, because sometimes, because of its low prevalence and positivity in IHC, maybe an NGS can use in picking up, and detection rate is quite high. So how are we going to do? Again, we always compare with the IHC fish. So NGS, the advantage is it's the potential benefit, and RNA NGS has higher sensitivity rate. Only disadvantage is the increase in the TAT. So the tumor turnaround time can be higher. So can lead to a longer wait. So we need to keep into consideration the patient's condition, the performance status, the disease burden, and what type of treatment are we going to give. So based on that, maybe if the patient is quite stable, then wait till the NGS report, or else get an IHC upfront if something is required. But important one, reflex to NGS, IHC is reasonable. But the notice, the final takeaway is the prevalence is quite low, because the fusion protein detection in IHC is quite less. So next, the other pathway, other target is the HER2. We all know that HER2 testing is quite common in case of breast and gastric tumors, but even in lung cancer these days, the incidence has come to 3 to 5% in adenocarcinoma. Mainly, it's the exon 20 insertion. It's the in-frame insertion which is noticed. For example, like in other cases, we might look into amplifications or overexpressions. Here, there is a mutation, see. That is the most important pathway. So if it's an amplified or an overexpression, maybe a fish is important. But for a mutation to be tested, NGS still hold good. And sometimes even IHC overexpression can also be seen in 59% of cases. So this is just a brief of how the treatment paradigm of lung cancer has evolved. Initially, we started with an era of chemotherapy for all patients, irrespective of the driver status. But currently, we are in an era of precision oncology, where a patient comes to us, you get the entire molecular profiling done. Patient has an EGFR mutation, maybe like DEL19 or L858R, based on, again, the signs, symptoms, whether you give osimertinib alone or osimertinib with the combination of chemotherapy based on the FLAURA2 data, or if based on affordability is a criteria, we can go with the other targets of Gen 1 and Gen 2 also. Now, we do have other preferred ones like decomatinib and all that can also be abimantinib, maybe in case of progressions or resistance. In case of ALK, again, if there is CNS mess, lorlatinib or brigatinib is upfront approved. But again, if there is no CNS mets or it's only a limited, or you can give alectinib or any crizotinib or ceritinib, etc., can be given into these patients. Again, in ROS1 targets, crizotinib and entrectinib have shown good benefit. BRAF V600E mutation, dabrafenib with trametinib combination has shown improved survival. NTRK, we know that two substrates are available, entrectinib and larotrectinib. If there is a red fusion, selpercatinib or pralsetinib can be given. And in case of MET, we do know that capematinib and tepomatinib can be given. And in case of KRAS G12C, sotorasib or adagrasib, but you can't use the same. If there is a progression with sotorasib, the next molecule cannot be used because of the same mechanism of action. So next, coming the most important. So till now, we know the targets which are available, the various expressions, the driver mutation. Most importantly, the PDL overexpression, which is seen in both squamous and adeno. So what are the various platforms? Again, it depends. The most commonly used are the DACO 22C3 for pembrolizumab. If you are giving atezolizumab, the Ventana platform SP140 to use. Again, durvalumab, it is SP263, mainly in case of the post-CCRT durvalumab maintenance. Nivolumab, again, the DACO 28-8 platform can be used. So we do look into the PDL1 expression, the TC score, the tumor composition scores, and also the PDL1 expressions and the CPS scores can be taken into pathway, which I'll be explaining in detail now, the scoring systems. So if we, this is just a pictorial representation to look into the staining pattern of how SP263, which is stained quite intensely here, coming to the SP142, but the most commonly used platform because of the 22C3, the DACO platform, which gives both the combined tumor scores, the tumor intensity scores. So currently the most commonly approved platform, which is quite convenient. If someone asks which is the most commonest, which can we use, can be 22C3 DACO platform. So the most important is whenever we are getting an entire gene panel testing done, PDL score is very important because if there is a target driver mutation, again, you focus mainly on the target pathway available. Even if there is a good expression of if there is a high CPS score, for example, like CPS score is quite good expressed, but still there's a target available, then you focus mainly on the targeted pathway mainly after the progression. So maybe if the patient is not responding or a poor responder, solely then the PDL1 drug can also be given into them. So this acts like a current biomarker to mainly guide the immunotherapy. So we do have data. If a CPS score is 50, you can give a single agent, anything between 1 to 50, a combination of IO with chemotherapy, less than 1. Again, it depends. We do have data for Novo ipilimumab combination, either with 2 cycles of chemotherapy or without chemotherapy, which has been published in the GCU article. So again, it depends. It depends upon the entire a holistic approach pathway has to be taken care, looking into the performance status, the disease burden, and what are the symptoms with which the patient present. Now, if you look into the other biomarkers, okay, so for example, like if PDL1 score is quite less or the CPS score is less, you still want to do TMB or an MSI in these cases. Still, we don't have a huge data for that. But yes, but these are the biomarker. If a patient has prognosed has received multiple lines of therapy, maybe in those cases getting a TMB and a tumor tissue agnostic therapy treatment can still be used. LAG3 is one of the most important thing which indicates a possible resistance to immunotherapy. These are just evolution of biomarker, and it's yet we don't have a current data. Other data are like TILs, their expressions. So this maybe in future we can see about all this also. So I would like to conclude saying that at this era of precision oncology, all the patients need to be tested. Initially, we started with a single gene panel. Now, currently, at least a multi-gene panel, 8, 12, or if possible, 18 gene assay is mandatory in all cases, a multiplex testing. NGS is quite easy because entire platform and all the molecules and even the resistant pathways and all the entire genomic profile can be seen. And more importantly, now the ideal tag time is 2 weeks, so the working hour is also reduced. As a result of high thorough platform of NGS, this enables us in testing, knowing the driver as well as the passenger mutation. So with this, just one more slide to add on, a brief conclusion. So what are the testing? EGFR can be done either with PCR or NGS. BRAF, again, NGS is still the gold standard. IHC can also be used or PCR for validation. KRAS, yes, NGS or PCR. ALK, we know that it's by fish and NGS also. ROS rearrangements, red rearrangements, fish, NGS. Any MET exon skipping rearrangement is by fish and NGS. The main thing is we need to look into the per se saying that NGS is the gold standard because you're entire getting the panel. But if the patient is not affordable, maybe these individual testing can be done. And other one, NTRK rearrangements. Rearrangements are good detected by fish. Amplification again by fish. HER2 mutations by PCR or NGS pathways. TMB definitely it's by NGS platform. So this gives an overview that if a patient comes to us, we have two scenarios. The patient who's quite economically affordable and the one who's not economically affordable. So we know that a patient who's quite economically affordable, you get a basic NGS testing of entire genomic panel. But if a patient is not affordable, upfront get an EGFR, basic testing like EGFR, ALK, ROS, at least these three. If the patient is still affordable, maybe you can add on with RET, MET, and NTRK and other ones also. So this is more like a broad molecule of profiling, which we have seen. So with this, I would like to conclude my talk saying that NGS, yes, the gold standard. We all know that and for PDL1 testing, we have various platform, let it be the DACO or the Ventana, depends upon the whatever the target we are planning to use is one way to choose the platforms. Another way is easy accessibility. We look into the tumor scores and also the combined proportion score, which can be given a single platform and can be tested. So with this, I want to conclude saying that precision oncology is the future go, and maybe in future we may get more of other biomarkers and predictive biomarkers. So with thank you.
Thank you so much, Dr. Nihanti, ma'am. So, is there any question? Okay, so moving ahead for the next session, and I would like to invite Dr. Animesh Saha, and he's a consultant medical oncology, Apollo Multi Specialist Hospital, Kolkata, and to give us talk about overview of lung cancer. So it's over to you, sir.
Thank you. Thank you for the kind introduction. Uh, I'll just try to share my screen. That's good. Yeah, is my presentation visible?
Yes, sir. Make it full screen. Yeah.
And am I audible?
Yes, sir.
Thank you for giving me this opportunity to interact with you. Uh, Myself, Dr. Animesh Shah, clinical oncologist working in Apollo Multi-Speciality Hospital, Kolkata. And I'll be discussing on some overview of lung cancer. I think Dr. Niyanti has done an excellent job with her presentation, and uh, quite a few things which I'm going to cover has already been covered. So let us start. So we know that lung cancer is increasing every day, every year, every month. You can see the Globocon 2020 data that in overall population, lung cancer was about 5.5%, but in male, it was the second most common cancer after head neck cancer, with incidence of about 8% in India. And for optimal treatment, we need to stage the patient optimally because the treatment is very important, and slight changes in staging that we have been using in AGCC 7 versus AGCC 8, depending on the tumor size, as you can see. T2B used to be more than 5 centimeter, but less than 7 centimeter. With N0, it was stage 2A. With N1, it was 2B. And more than 7 centimeter was 3B, which has now in AGCC 8 became the 3A disease. And tumor more than 5 centimeter to 7 centimeter with N1 disease, which was previously 2B, now has been in stage 3A category. So whenever a suspected lung cancer patient comes to us, we evaluate the patient clinically, take a detailed history, routine blood tests are done. First test would be a CT chest, and depending on the location of the tumor, we do either a CT guided biopsy or a bronchoscopic biopsy or EBUS guided or use guided sampling. And it is followed by a PET CT scan. When we decide that EBUS is probably not adequate or not representative, but doing a mediastinal sampling would probably change the management of the patient. A mediastinoscopy should be considered, and most of our patients, unless a very early stage, we should do an MRI brain for completion of the staging. And when it comes to CT versus PET CT, I think most of us now practice routinely PET CT scan and lung cancer staging workup. And a CT scan with a lymph node of more than 1 centimeter in shorter axis, the predictor of cancer spread. Say CT is low in terms of sensitivity and specificity, and with addition of PET CT, the overall sensitivity is quite high, ranging from 80 to 90%, and specificity of 85 to 95%. And what are the risk factors for uh, mediastinoscopy or mediastinal staging. Uh, Central tumor, size of the tumor, more than 6 centimeter size, is a predictor of mediastinal nodal spread. Higher SUV on PET CT scan is also an indicator, with particularly if the SUV is more than 4. So next is why what kind of mediastinal staging investigation we should do. Uh, I would say it's less invasive, EBUS or EUS. Should always prefer the less invasive one. Mediastinoscopy should be done or should be considered in very selected cases. I'll come to the indication where we should do it. There are various forms of mediastinoscopy: conventional open technique, VAMLA or video assisted technique, TEMLA or trans thoracic technique, VATS. So EBUS or EUS is a standard mediastinal staging investigation that most of the cancer facilities should have. When invasive mediastinoscopy for mediastinal staging is indicated, centrally located tumor, yes, tumor size more than 3 centimeter, extensive infiltration of the mediastinum with no evidence of extrathoracic disease or positive N1 disease, yes, bulky N2 on CT, no needed for the invasive confirmation, discrete N2, yes, regardless of the PET CT result. Normal mediastinum on PETs on CT, but positive on PET, yes, we should do mediastinoscopy. This is kind of an algorithm of doing a mediastinal staging. And you can see that in most of the cases, we should aim for a non-invasive approach with EBUS and EUS. And sometimes if the nodes are large, bulky, if positive, you might not need node, might not even need mediastinal sampling and straight away proceed to the multimodality treatment. These are the various approaches, and then which group of lymph node or mediastinal lymph node they can be used for accessing. And this is the sensitivity of various modality, non-invasive to invasive. You can see a PET CT has got a moderate sensitivity. If you do EBUS or EUS, it's about 89%. Mediastinal staging with mediastinoscopy, the sensitivity is around 81%. But if you do with VAM or EBUS or EBUS and mediastinoscopy, when they are combined, the sensitivity increases up to 94%. And VATS has the highest sensitivity of 99%. Evolution of lung cancer treatment. So it was previously considered to be a single disease until distinct subtypes and characteristics were identified. Non-small cell lung cancer are now distinct type, subtype, and molecular subtypes are also there. Markers, biomarkers, PD-L1 expression, tumor mutational burden, etc. So now we are in the era of precision oncology, where more and more targeted therapy or checkpoint inhibitors are coming up, and we are moving away from traditional form of treatment like chemotherapy. And it has been seen that advances in management of lung cancer have significantly improved the survival of the patient. A significant increase in approvals of both targeted as well as immunotherapy in non-small cell cancer, lung cancer can be seen in last decade. And these are the various targets that we look nowadays for using any targeted therapy in non-small cell lung cancer patients. These are the current guidelines, the basic structure, how we should treat lung cancer, non-small cell lung cancer based on the stage. Stage 1A, we need to do surgery, and this is followed by no further adjuvant treatment or neoadjuvant treatment. Simple observation is okay for 1B to 2A. Adjuvant chemotherapy is considered in high-risk patient. No proven benefit of neoadjuvant chemotherapy. Stage 2B adjuvant chemotherapy is definitely indicated, but again, no proven benefit of neoadjuvant chemotherapy. Stage 3A and 3B, neoadjuvant chemotherapy or adjuvant chemotherapy is indicated, and radiotherapy in selected group of patients. And now we've got neoadjuvant immunotherapy, adjuvant immunotherapy, and TKI is coming up. Finding a surgery and resection margin also affect adjuvant treatment decision. As we know from lung arc trial that if the positive margin is there, we need to consider adjuvant radiotherapy because it reduces the risk of local recurrence. But after initial management of patients with resectable non-small cell lung cancer, there are about 50 to 60% chance of recurrence even after surgery. And that's why the adjuvant therapies are important. And this is the ESMO guideline, quite old to be honest. Uh, but the role of adjuvant chemotherapy was established quite early. More than 4 centimeter tumor, node positive tumor. We used to give chemotherapy, and we're still giving adjuvant chemotherapy. And this is based on this meta-analysis where cisplatin and vinorelbine was used as an adjuvant chemotherapy, and it showed 5 years survival benefit of about 5.4%. And how well the neoadjuvant chemotherapy works as compared to adjuvant chemotherapy? Pretty well to be honest, with similar hazard ratio for stage 1B to stage 3A patients. Targeted therapy are now coming up in the early stages. The ADULA trial data when a patient with completely resected stage 1B to 3A EGFR mutated lung cancer patient were randomized between placebo versus osimertinib for 3 years, and it showed significant improvement in overall survival and disease-free survival. With introduction of EGFR TKI, DFS is improved from 44% in placebo to 90% at 12 months. In survival in adjuvant setting in patients who had PD-L1 more than 1%, such therapies will help improve the survival rate in non-small cell lung cancer patients. Lung cancer radiotherapy has evolved over time, and in the current era, there is hardly any center which are using conventional technique or 3D CRT. Most of us have moved from that to IMRT or intensity modulated radiotherapy. And colleagues like medical oncologists and pulmonologists, we use for early stage, we do stereotactic radiotherapy with a large dose per fraction with smaller number of fraction. We use 8 to 20 gray per fraction in 1 to 5 fraction. It's a very precise high dose radiotherapy. And we use routinely motion management techniques like 4DCT, image guided radiotherapy, adaptive radiotherapy. And with more use of this technique, what we are doing is basically targeting the tumor precisely and reducing the dose to normal organ. So there has been attempt of dose escalation in RTOC 0617 trial, where conventional 60 grain 30 fraction were compared to 74 grain 37 fraction. And what we have seen that with dose escalation, there is no improvement in overall survival. Actually, the dose escalation were detrimental for the patient, and based on that, we stick to the conventional or 60 grade 30 fraction with concurrent chemoradiotherapy for most of our patients. However, there has been newer attempt because the concept of dose escalation in the RTUG 0617 trial was based on uniform dose escalation throughout the PTB, and now we are going for more and more highly precise dose escalation. And there are a couple of concepts coming up: dose painting by contours and dose painting by numbers, where we escalate the dose to SUV or the PET avid area, or escalate the dose based on the incremental escalation of SUV uptake. So non-uniform or targeted dose escalation are now hot topic that we are doing. Pacific trial where concurrent chemoradiotherapy followed by adjuvant durvalumab were used, and it showed the significant improvement in overall survival. Durvalumab demonstrated 43% 5-year overall survival benefit, which used to be uh, about 15% to 20% previously. Emerging treatment with chemotherapy, the median PFS was about 5 to 7 months. With EGFR TKI, it has increased to about 19 months, and with ALK TKI, it has gone to 35 months. And there is various targeted agents, as Dr. Niyanti already discussed about the targeted therapy with various other mutation. For MET mutation, we've got crizotinib for RET, cabozantinib and bandectinib, LOXO 292. NTRK rearrangement, we have larotrectinib, entrectinib. For HER2 mutation, we now have arotrastuzumab, emtasin, etc. And these are the basically survival outcome with various TKIs. Now coming to checkpoint inhibitor, the two main pathway, the PDA1 or PDL1 inhibitor and CTLA4 blockade. And these are the various drugs which has got approval starting from 2015 Pembro to current approval of 2021 semi-plebia. So, and these are the outcome of various immunotherapy trials. So this is a Kaplan-Meier survival curve from Keynote 0 to 4, which showed an improved survival in patients with pembrolizumab alone compared to chemotherapy in PD-L1. More than 50% patients, almost 32% patients were alive at 5 years with use of immunotherapy alone in metastatic non-small cell lung cancer. And now we are looking into the use of checkpoint inhibitor in earlier stages, and multiple ongoing trials are happening. Pearl's Keynote 091 for Pembro, PR 31 for Durva, and one for Atizo. What's new? Antibody drug conjugate. We have already approved in breast cancer, adotrastuzumab, emtasin, adotrastuzumab, and now the ADC are also coming up in big way in lung cancer, and CAR T cell therapy is also coming up in lung cancer along with various other cancer. So to conclude, the management landscape is fast changing in non-small cell lung cancer. Neotherapy has a huge potential to improve survival, especially when detected in the early stage. Overall survival has improved across various subtypes and molecular alteration as we are now moving into the era of precision medicine. The ease of oral pill over infusion in case of targeted drugs is an added advantage. And we should also acknowledge that it's a multidisciplinary teamwork, and we need all the specialty, medical oncology, radiation oncology, pulmonology, radiology, pathology, molecular biology, team member to come up together in decision making of these patients. That's all for me. Thank you for your kind listening.
Thank you so much, Dr. Animate, sir. So, is there any question? So, thank you. So, moving ahead for the next session, and I would like to invite Dr. Parag Roy, and he's a consultant medical oncology TMH Jamshedpur, and to give us talking about reimagining CNS mutation in EGFRM, advanced lung cancers, how treat compare. So, it's over to you, sir.
Good evening.
Yes,
Am I audible?
yes, sir.
Okay. My screen is visible.
Yes, sir.
Okay. Good evening, all, and thank you for the sponsors for giving me this opportunity. And before starting the talk, Dr. Animesh has already discussed the overview of lung cancer management. So, my topic will be mainly the TKI portion. If the patient presented with EGFR mutation with CNS metastasis, is there any special approach for that? Coming to the basic, we all know the incidence. We have discussed this many more times, and there is almost 85% of non-small cell lung carcinoma and 15% is small cell, and the main mutation burden in the metastatic non-small cell lung carcinoma will be EGFR. This data is showing is from the Western data, and it is 17%. The other is BRAF, MET, and we have already seen in the previous discussion this. So it is almost 80 to 85% is non-small cell, and EGFR is the most common variant. But difference is the from the other side of the world. We are lucky enough in the Asia zone or in the Eastern zone, the EGFR mutation is much more. Even in Indian scenario, this data varies to from 30 to 40, 45%. Even in TMH data, they have published it. So it's almost 40 to 45% in our subsite. EGFR mutation is positive, and the typical presentation on of the EGFR is that there is brain metastasis presented with that. In some have symptomatic brain metastasis, some have asymptomatic brain metastasis, and there is asymptomatic brain metastasis is approximately at the time of presentation with symptomatic and asymptomatic 10 to 20% of patient with EGFR mutation has a brain metastasis. And in during the course of treatment, the EGFR mutated patient, there will be approximately 40 to 44% of patient will have brain metastasis, in comparison to only half of the patient, that is 20% patient will develop brain metastasis in wild EGFR patient. Even they have has a higher tendency to leptomeningeal spread, which have a very dismal outcome, only measured with several weeks, 4 to 6 weeks. And in leptomeningeal metastasis is approximately 10% in non-small cell lung carcinoma. This slide is quite interesting that they have evaluated some patients with the presentation of the multiple metastatic site like adrenal, liver, bone, brain. What are the quality of life which affects depending on the metastatic site? The lower the value zero, it is the more decline of quality of life, and this upper the value is quite a normal quality of life. They have kept some variable like mobility, self-care, activities, pain, depression, and divided in 5 more subcategory, and depending upon severity they have put a mark, and the mark depends from the 0 to 100, and some of the marks after this is put in this graph. So in brain metastasis and in bone metastasis, if there is present, this affects the quality of life very significantly. In brain metastasis, we have discussed this previously, that it is a sensory site from the site for invading metastatic tumor, as protected by blood-brain barrier, and 40%, 40 to 45% patients with non-small cell lung carcinoma with EGFR mutation with develop brain metastasis in the course of the treatment or course of the disease progress. And some of the transporter which helps that EGFR TKI to concentrated in blood in brain, and these transporters helps helps the different molecule of TKI to make an equilibrium in the brain depending upon the generation of TKI, like first generation, second generation, and third generation TKI. Mostly the third generation TKI will have a very good blood-brain barrier penetration, and will be high concentration will be available in the brain. Most of the third generation, like osimertinib and lazertinib, have this activity to concentrated in the brain. If you see the clinical studies from where we get this that osimertinib, that is third generation TKI, which irreversibly inhibit the EGFR. The see this study that in all other molecule like erlotinib, gefitinib, which are the first generation TKI, there is no brain radioactivity is shown in this graph. Like from red will be higher radioactivity and blue will be lesser radioactivity. There will be in first generation TKI, there will be less chance of crossing the blood brain barrier. On the contrary, if in the third generation TKI like osimertinib, there will be a higher concentration in the brain, so blood brain barrier will be penetrated most effectively. These preclinical studies, the dose has been given as per mg per kg. We've seen this compared with third generation with other first and second generation like gefitinib, afatinib, and the peak blood plasma ratio is much higher in the osimertinib arm, and in comparison to other almost 3 to 4 times higher than the first generation and second generation TKI. And if we look into this graph, the radioactivity which is present in the brain will be very much, there will be steep rise in the graph, and there will be a and plateau on the osimertinib, and regard in comparison to that, the radioactivity will be very less in the other gefitinib, afatinib, or rosilatinib molecule. So even these preclinical studies which was done in the animal had showed that osimertinib has highest brain penetration. This they have this clinical studies, what they have done, that they have inject the tumor cell, and there will in the mouse, and there will be tumor development, done this tumor biopsy, and EGFR testing, and there will be EGFR testing, and after giving the osimertinib, they have seen that there is tumor regression. This is the brain imaging which was presented in Chicago in radiology conference, and what they have done, this in this healthy individual, they have done this full body PET with 11 C osimertinib, and in brain, in normal subject which they have no history of any carcinoma, or non-small cell lung carcinoma is present, they are all healthy volunteers. In they have what they have seen that in all most of the subject in healthy individual, there will be a higher concentration of osimertinib, and quite obvious distribution in the brain, which is seen as a color indicator here. In patients, after giving the osimertinib, how they have reached the concentrated amount in the brain. In this picture, we have seen that done with the PET. This is the patient number one. This is the blue one is the least concentrated amount in the osimertinib in the brain, and the yellow or red is from the higher concentrated amount. So from day 1 to day 21, after 20 days of osimertinib 80 mg, even there is a significant increase in the volume of distribution in the brain, and same also we have seen in the patient 2 also. So we know this that osimertinib is third generation TKI, irreversibly bind to mutant EGFR kinase form, even with addition of the say, T790M mutation, which is the most common resistant mechanism after third generation of TKI, and prolongs the OFS and PFS. The OS data in the long run, we have seen that almost 39 months in comparison to first generation TKI, exhibit anti-tumor effect in non-small cell lung carcinoma with a EGFR mutation, even in uncommon mutation, they have seen their activity. High blood-brain barrier penetrance seen in we have already seen in the preclinical studies and in healthy individual, and also in the patient in active CNS against the CNS metastasis. Even the patient without CNS metastasis, there is crossing of blood-brain barrier with osimertinib, and inhibit growth of CNS metastasis patient with EGFR mutation positive non-small cell lung carcinoma. So coming to this trial of Flora trial, efficacy which is compared efficacy of osimertinib compared to third generation TKI, gefitinib and arlotinib. What they have done, that they have uh, gone for almost 900 of patient, and eligibility as per eligibility criteria, the EGFR mutation of exon 19 deletion and L858 are mutation, more Asian and non-Asian. Most of majority two-third was Asian people. In almost 900 patient, only as per the inclusion criteria, almost 556 patients are eligible for this trial, and this was a double-blinded trial. Worldwide patient was taken, and mutation exon 19 and 21 mutation, and even CNS metastatic disease were taken. Two arm osimertinib arm, patient was 279, and comparator arm was arlotinib and gefitinib, first generation TKI. Looked for progression-free survival and overall survival, and majority have patient have metastatic disease. Almost 95% have metastatic patient, and 21% percent of patient has CNS patient CNS metastasis at the time of presentation. The major drawback of this trial 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 that there was no CNS routine CNS imaging was done. Only symptomatic patient have done the say CNS imaging, and in contrary to Flora 2, the all of the patient have done CNS imaging. So in that Flora 2, the CNS metastasis patient are almost 40%. If we see this graph, then osimertinib, the number of patients were equally distributed, and the median PFS was 19 months in the osimertinib arm, and the experimental arm, and in the comparator arm in the first generation TKI, it is 10 months, and median OS is 38.6 month, and 31 month in gefitinib arlotinib month, with impressive hazard ratio of 0.46. And if CNS FAS, that is food analysis set, only almost comparable 61 versus 67 patient, and but the in the osimertinib and in the first generation TKI arm, but the median PFS is yet not reached in the osimertinib one, whereas the first generation TKI had almost 14 months. And osimertinib had significantly longer OS in comparator to first generation TKI. If we see after 2 years of result, 74% patient in the osimertinib had longer OS and versus almost 60% in the first generation TKI. The CNS analysis report, there is this look into the graph that there is wide separation of the graph from the very beginning. This indicates that the early separation of curve is due to low frequency of early resistance of the osimertinib, in contrary to the first generation TKI. And in with a hazard this or for CNS metastasis, known or treated CNS metastasis, and hazard ratio of 0.47, and without CNS metastasis, the PFS is also widely separating from the very beginning, and this and is for osimertinib has superior PFS benefit in regardless of CNS disease status in comparison to the first generation TKI. In CNS report, we have discussed this, and um, the CNS pool analysis report that is a fast, wide separation of the curve and impressive hazard ratio of 0.48, and PSFS is statistically significant with osimertinib versus the first generation TKI. And CNS progression is only very much less, almost half, that is 20%, if patient is receiving the third generation TKI, and almost double, that is 39% in first or second generation, sorry, in the first generation TKI. This is the flora result in the long run. In the first month, there is almost patient 70% patient is still on the osimertinib arm, or versus almost 47% in first generation TKI. After 2 years, 42% is in receiving the osimertinib, and 16% continuing to receiving the odlatinib or gefitinib. And after 3 months, 9% in patients are receiving the first generation TKI, and almost 3 times patient are receiving the osimertinib in this FLORA trial. Some real world trial which is provided by in this interaction class. Intracranial response to osimertinib without radiotherapy in non-small cell lung carcinoma with present of T790 mutation. Case report. These are the on case report in mainly published in Japan. So this patient, 67-year, 100 right middle lobe resection 9 years ago, multiple modes in 7 years ago, and the mutation was exon 18 L858R mutation, second most common mutation. Gefitinib was given for the first line, almost 3 years, then received multiple line of chemotherapy, almost 6 lines of chemotherapy received, and received radiotherapy. And at that time biopsy was done. The most common mutation after first generation TKI resistant mechanism, 790M mutation seen in exon 20, and started osimertinib. This is the picture. The brain metastasis present from the very beginning, pre-treatment, and after 13 days there is almost disappearance of all the brain metastasis even in the lung, and only single metastasis was present was after 13 days of chemotherapy. This is the second case of 76-year-old male patient, had a history of smoking, and with EGFR exon 19 mutation positive. There is multiple bony metastasis present. Received first generation TKI gefitinib for almost 4 years, and after that, afatinib second generation TKI was given, and with chemotherapy arm with bevacizumab and carboplatin pemetrexed, multiple line of chemotherapy, and then done a biopsy, and additional mutation of T790 mutation was seen. Oxymotin started on fifth line, and after 14 days, there was shrinkage of pulmonary nodule, disease appearance of pleural effusion. So very good response. This is the brain metastasis, decrease of brain metastasis after 10 days of treatment, and shrinkage of this pleural effusion uh, after 30 days. And this is the third case report of complete remission of multiple brain metastasis after osimertinib without radiotherapy. And 74-year-old woman, stage 4 disease, exon 9 deletion mutation detected, and there was multiple brain metastasis, lung metastasis. So started osimertinib, and after 5 weeks of osimertinib, there is almost complete CNS uh, uh, response. No CNS metastasis has been seen, and this is intracranial response of retrospective trial of 36 patient in on osimertinib in EGFR mutation of mutant non-small cell lung carcinoma. Total 36 patients were taken and given osimertinib for the brain metastasis. All and post. This is one example of one patient that who had a CR after and 2 months, and continued had response in the brain imaging for almost 3 years post osimertinib. In this total 36 patient had brain metastasis, and 2 year overall survival were 80%, and CSN progression rate were 1 year, 2 years, and 3 years were post osimertinib was 21%, 32%, and 41% respectively. So, what are the recent guideline? What we just before the recent guideline, let me share my experience. I had a patient of metastatic lung carcinoma, non-small cell lung carcinoma with lung metastasis, and he started on chemotherapy, and uh, chemotherapy with osimertinib, and as patient affording in our current scenario, and after some days, after 3 to 4 cycle, had one single brain lesion. So patient was complaining of some headache, or they were investigated for some other cause, but we luckily got some incidental or maybe correlating with the headache, had a brain single brain metastasis, give SBRT, and after that was continued osimertinib, and patient still almost more than 1 year. So there is no other brain lesion, and the primary is also controlled. So we'll look forward for this patient, that what the long term the patient will survive or not. And what is the recent guideline says? This is the slide from 2025 NCCN guideline in EGFR exon 19 deletion, or 21L858 mutation, or in uncommon mutation also. Osimertinib is the category 1 recommendation, and this osimertinib, we have discussed this regarding on basis of the FLORA trial, but in our current scenario, the FLORA 2 data have came, which has added osimertinib. The backbone is the same with addition of chemotherapy. So they have put this also in the osimertinib, pemetrexed, and carboplatin. So osimertinib remains in the majority. With this, I'm concluding my uh, discussion today. Thank you all for patient listening.
Thank you, Parag sir, for the such a nice talk. For the next talk, I would like to invite Dr. Amit sir. Sir, Amit sir, the stage is all yours.
Sharing. I'm not able to share my slide.
Parag sir, kindly stop sharing your slides, please.
Yes.
I think my slides are visible now.
Yes, sir. Kindly make it as full screen. Yes, sir. Now it's visible and my full screen as well.
Uh, okay. Yeah. A very good evening, everyone. I'm Dr. Amit, consultant medical oncology at Max Dehradun. And today I discuss the treatment dilemma between monotherapy versus combination treatment in advanced EGFR mutation non-small cell lung cancer. So the topic which I will cover in my next slides will be the burden of EGFR mutation in non-small cell lung cancer. What are the risk factors and the poor prognostic factors? What are the challenges in the progression with the monotherapy? And the trials of head-to-head comparison of mono and combination treatment. So if you'll see EGFR mutation overview, we all know that it is the most common targetable mutations, and the prevalence is different between Western and Asian population. If you talk about the India, the incidence is around 13.3 to 39%, while in Western it is like 15 to 20%. In EGFR, the most common ones are EGFR exon 19 deletion and exon 21 L858R, which consists 19% of EGFR mutation. Other rare mutation can be exon 18 and exon 20 insertion. So if you see the prognosis of the non-small cell lung cancer stage-wise, we know that as the stage increases, the survival decreases. And the 5-year survival is only 2% for the stage 4, while for the stage 1, it is around 50%. While if we'll see about, the patient who are harboring the specific mutation like EGFR, ELK, ROS1, the survival is slightly better if you compare the other patient who does not harbor these mutation. For EGFR mutated non-small cell lung cancer, the median overall survival is 3.1 year. But I will be slightly disagree with this because the survival nowadays with the treatment is more than that. When we see the patient who are not harboring these mutations like EGFR non-mutated lung cancer, the survival is around 1.6 year. During the treatment also, you have to continuously monitor the patient for the disease progression. And if the patient has undergone surgery earlier, so we have to monitor those patients for the recurrence, because we know that the chances of recurrence after surgery is also high in the lung cancer. But we all know that this monitoring does not improve the overall survival. But if we detect this recurrence early, it can increase the disease-free survival and improve the quality of life of the patient. So talking about osimertinib, is the third generation irreversible CNS active EGFR TKI, which act not only on the EGFR mutation, exon 19 and exon 21, but also act on the resistant mutation, EGFR T790M mutation. So it does not act on the wild EGFR receptor, but it act actually really well on exon 19 and L858R. And this exon T790M mutation, which actually most common mechanism of resistance with the first generation. That means if we are patient on first generation TKI like gefitinib or erlotinib, the cause of progression is this mutation is in like 50% of the patient. Another good thing about osimertinib is that it crosses the blood-brain barrier. So CNS progression is very less compared to other first or second generation TKI. So what is the rationale of adding chemotherapy with TKI? This is really interesting, and it has been tried earlier as well. So when we add chemotherapy with TKI, it induces the apoptosis and also suppress the AKT and extracellular signaling, regulating kinase phosphorylation, which delay the resistance to the TKI. It also decreases the thymidylate synthase levels, which may enhance the efficacy of the pemetrexed, which is a chemotherapy backbone in non-small cell lung cancer, especially in adenocarcinoma. If we see the previously trials which incorporated TKI along with the chemotherapy, they definitely shows a better PFS and overall survival. And the one study which really took the attention of all over the world was TMH study, where the gefitinib was added along the chemotherapy, and it showed not only the PFS but survival advantage. So if you see this was the first line treatment approach for the EGFR mutated lung cancer, I'll say like 2 or 3 years back, where initially first generation TKI came, then second generation, then there was some combination like allotinib plus anti-angiogenic drugs, bevacizumab or ramucirumab. Basically, this diagram is showing the combination ap- treatment approaches which we have right now is this trial, I think relay trial, allotinib plus bevacizumab, and the PFS was 16 months. When we added chemotherapy along with gefitinib, the PFS went to around 20 months. We have second generation EGFR TKI, which is having PFS around 14 months. And if we are giving osimertinib alone, the PFS is around 19 months. So if we compare osimertinib as a single drug compared to allotinib plus anti-angiogenic or first generation TKI plus chemotherapy, osimertinib is still better to those combinations. So in further slide, I will discuss now they have incorporated chemotherapy with osimertinib. So this is the EGFR mutation landscape evolved over the time. It was first identified in 1978, and the first time gefitinib was approved in 2003, and that time it was for all patients, all unselected non-small cell lung cancer. Then they saw that the response was more in patients who were harboring EGFR mutation. And in 2013, FDA approved apatinib and allotinib in EGFR mutation non-small cell lung cancer. And then in further 2015, they got to know the mechanism of resistance with the first generation TKI, which was T790M mutation. And then osimertinib came into action, and it was approved in 2018 as a monotherapy. And now from 2018 to 2025, osimertinib is also approved in the adjuvant setting as well. Not only in the adjuvant, but after definitive CTRT, also in the LAURA trial, osimertinib is approved in the maintenance therapy. So this is a FLORA trial. There's a FLORA, I think FLORA 1, and it was showing that if we are giving osimertinib, the benefit was seen in all the subgroup of the patient, and there was a survival advantage as well. So the PFS specifically for the Asian subset was around 17 months. So this was the FLORA takeaway, that osimertinib was the first drug which showed not only PFS advantage, but the overall survival advantage as well. And if you compare osimertinib with the second generation TKI, the drug discontinuation rate was less, and the skin toxicity with the osimertinib is less compared to the second generation of TKI. When we give second generation of TKI like decometinib or apatinib, the skin reactions are very high. Another point to be considered is that sequencing cannot be, it's a best approach. We have to give our best treatment as early as possible, because in second line, like 70% patients were not even eligible for the osimertinib. Osimertinib is usually well tolerated, and the dose is 80 mg once daily, and it crosses the blood-brain barrier as we talked about. This is a very good slide showing the PFS with the drugs. Like for gefitinib, the median PFS is around 9 months, and for the osimertinib is up to 19 months. For the second generation, which is showing in the green, it is for apatinib, the median PFS was 11 months, and for decometinib, it is around 14 months. So even if we add chemotherapy with gefitinib, the PFS is somewhat around to the osimertinib. Like if you are adding pemetrexate carboplatin with the gefitinib, we are reaching of the PFS up to 18 or 19 months only. If we are using bevacizumab with allotinib, we are reaching up to this PFS only. So now what will happen if we add chemotherapy with osimertinib? So that we will discuss further. So this is the OS outcome. This was the PFS of the previously used drug. And if you see, the OS benefit was not there for the first generation or for the second generation. For the first time, the third generation TKI showed the overall survival advantage, and the median overall survival was 38 months. So this is the trial where osimertinib was combined with the chemotherapy first time in the FLORA-2 trial. The studies population was the same. They were pathologically confirmed adenocarcinoma harboring EGFR mutation exon 19 and exon 21 point mutation. They were randomized in osimertinib plus chemotherapy, followed by chemotherapy and osimertinib maintenance versus osimertinib alone. And the primary endpoint was PFS, both by investigator and blinded central review. And the secondary endpoint was overall survival response rate. The baseline characteristics were well balanced. And another important thing which need to be focused is around 42% patients were having baseline brain metastasis, which usually considered as a very poor prognostic factor. So if we see the progression-free survival, it increases from 19 months to 25 months. So when we add chemotherapy with osimertinib, now we are getting benefit of around 6 months in the progression-free survival, which is, the highest if we compare to with the previously used approaches. We'll see with the blinded central review, the progression-free survival was even higher. It was 29 months compared to 19 months. The benefit was seen across all subgroup, whether the mutation was exon 19 or L858R. The benefit was seen in all subgroup. If we see the PFS in CNS metastatic patient also, so the progression-free survival was around 24 months, which is really good. The patient with brain metastasis were living more than 2 years. It's a big achievement. And the benefit was seen across whether it was exon 19 deletion or L858R. In FLORA, we saw that the benefit was slightly less in L858R, but with adding chemotherapy, the benefit was seen in, equal in both mutations. If we see the mechanism of resistance with chemo plus osimertinib, it is almost same like if we are giving osimertinib alone. So whether it is a EGFR mutation, which is C797S mutation, or MET amplification or amplification, it is almost same in both arms. If we talk about the safety profile, which is really important, we'll see that the grade 3 toxicities compared to osimertinib and osimertinib plus chemotherapy arm were higher, 64% versus 27%. But majority of the toxicity was hematological and it is well manageable. But it is seen in all combination trial, whether it is gefitinib plus chemotherapy or gefitinib plus anti-angiogenic treatment, it was seen in all trials. If you see the efficacy, if you see the response rate 80 with osimertinib, which is the highest compared to other trials which were using chemotherapy or single agent TKI. And if you'll see the PFS, in FLORA, it was 18 months, which was highest. And we are, with adding chemotherapy, we are increasing this PFS up to 25 months. So what are the newer treatment options for EGFR mutation non-small cell lung cancer? We know that osimertinib is there, but after coming of this Mariposa trial, amivantamab plus lazertinib, it is also offering the same PFS, almost same PFS, but the toxicity is slightly higher with amivantamab plus lazertinib. Amivantamab plus chemotherapy can be utilized in the second line treatment, which is showing PFS of around 8 months. So this is the new, options are coming up with the time. So this is a future trial can be ctDNA monitor, to choose the better treatment option. This trial basically designed to start with the osimertinib and to see the ctDNA level. If the ctDNA is still positive after 3 weeks, they are using combination treatment. Otherwise, they are just giving the single agent osimertinib. So the current treatment outcome, if you'll see with the Flora, we have used osimertinib and getting PFS around 18 months. And if there's a progression, we have option of chemotherapy, which is giving us PFS of 4 months. Or if we are using amivantamab plus lazertinib, it is giving us PFS around 5 months. In Flora 2, the PFS has increased up to 25 months. And after that, we have seen some trial of, we have option of amivantamab plus lazertinib, which is giving us a PFS of around 5 months. In Mariposa, they are giving amivantamab plus lazertinib upfront, which is showing the PFS of around 23 months. And in Mariposa 2, they are giving osimertinib followed by chemo plus amivantamab plus lazertinib. So these are the different options which we can utilize according to the patient. And if we talk to myself, I think osimertinib plus chemotherapy is a good option. And if the patient is having progression, we can do again liquid biopsy or tissue biopsy to see the mechanism of resistance. And if there's no specific target, then we can switch to amivantamab plus lazertinib. So the pros of combination therapy is it is a comprehensive approach. Chemotherapy plus TKI is having a synergistic effect. It is using increasing apoptosis. Sorry, I have to take this call. Wait a second. When we add chemotherapy with TKI, it is delaying the resistance. That is really important. It is improving the outcome as we saw that PFS has increased 6 months, and we know that it is having synergistic effect. Cons of this treatment strategy is that increasing toxicity. The grade 3 toxicity increased from 27% to 67%. It is the complex approach. Many, some of the patient cannot tolerate it, and the cost is another issue because for the chemotherapy, the patient has to readmit after every 3 weeks. If we compare with the Flora versus Flora 2, we know that PFS has increased. OS is also, though it is not reached now, but we are hoping that it will also show the OS benefit. The CNS effect is better, but the toxicity is more in chemo plus osimertinib. The anemia was around 47, diarrhea was 44%. The another important thing is the L858R mutation. The PFS in L858R with osimertinib alone is 14 months, while when we are adding with the chemotherapy, it is around 28 months. So in summary, osimertinib with combination of the chemotherapy is showing significant and meaningful improvement in the PFS compared to the osimertinib alone, which is around 25 versus 16 months. And blinded central review, the median PFS is showing around 30 months. The PFS benefit was consistent across all subgroups. In patient with a CNS metastasis at the baseline, osimertinib and platinum-based therapy reduces the risk of CNS progression. And the safety profile was expected for each treatment, and they were manageable. We are using this in our clinical practice, and it is really, well manageable. With this, I will conclude my slides. Thank you. This is it from my side.
Thank you so much, sir, for your excellent talk. So now we conclude our today's session. So thank you so much, everyone, for joining in today, and have a good day and good night. Bye, sir.